you're on.
Okay, so we're on.
Okay.
All right. Good morning. Welcome to Doc Talk Live.
Thanks, Brad.
April. This is April Maddux, by the way. April is a breast surgeon.
I'm a breast surgeon.
A breast surgeon. And for people that are just sort of finding out about this show, Doc Talk, and even for you, I want to sort of give you a little bit of background.
Okay.
And that is, what I'm trying to do is I'm trying to say that anything in healthcare is really interesting. At least it is to me, and I want to be able to share it.
Right.
And the other thing is medicine is happening all the time.
Right, and always changing.
And always changing. And I want to create something that's not scripted. Even this is a little bit scripted for me.
Yeah.
So I have your son as our cameraman.
Right.
And if he wants to turn the camera around and show him, that's fine. That's up to Lance. But the whole idea is for this not to be scripted, for this to be natural.
Okay.
It's obviously Breast Cancer Awareness Month.
That's right.
And what I want to talk about makes me the wrong person to do this interview, but I'm it. You're stuck with me. Which is, I want you to imagine that a friend of yours is concerned about breast cancer.
Right.
And they come over on a Saturday morning, you're having your coffee, you're with your family, but they want to talk about breast cancer because of the obvious concern. And that's where I want to start with this discussion. That's not a question, it's more of, hey, that's what's on my mind. What are your thoughts on that?
Well, I guess my thoughts are, it's something that affects everybody. Pretty much every family at some point will be affected by it. When you think of the numbers, 1 in 8 women, if they live to the age of 80, will be affected by breast cancer. So you just line up 8 women, and every 8th woman will be affected in some form or fashion. And so when we think about that, that's huge. I mean, those are huge numbers nationally. And I think that America does a pretty good job of screening for it. I really do. I do think the cost of screening nationally is a lot of dollars when we look at healthcare dollars.
Do your friends call you up and say, hey, what do you think? They might be in another state. I mean, they know that you're a breast cancer surgeon or a breast cancer specialist.
Right.
Tell me, is there a conversation that might come to mind that you could share about that?
Sure. I mean, I have friends all the time that'll say, hey, you think I need to get something done? I'm having some breast pain, or, I felt a lump. Can I come in and see you? And of course, I'm like, absolutely, come in. You should tell me, like, right now. I'll see you tomorrow. I'll see you today if I'm in the office,
With genetic testing, I had somebody tell me that they were so concerned that they went ahead and just got genetic testing.
Sure.
They got tell us about BRCA or whatever it's called.
Right. So the genetic testing's been around almost 20-something years now. The original BRCA genes were found in New York City and the Ashkenazi Jewish population, but then we found that there's more genes than that. So originally we found it was in BRCA1 and BRCA2 were the genes in the people, and these genes are, what I mean by that is it's really a mutated gene. And it's a mutated gene that increases the risk of developing breast as well as ovarian cancer and other cancers. But as genetic testing and science in and of itself has expanded, we found that there's more than just these genes. There's many more genes related to breast cancer.
But she was so concerned that she was like, if I'm positive, I'm going to just go ahead and get a mastectomy, a prophylactic mastectomy.
Right. Depends on the gene. It depends on the gene. I mean,
so is there a gene that you would say, hey, this is a particularly bad gene?
Yes. So when we
what's
do
the
genetic,
gene? I'm sorry.
Well, BRCA1 and BRCA2.
Okay.
So, and then there's others. There's like CHEK2 mutation. There's PALB2 mutations. There's others out there, and they can be just as pathogenic. And what I mean by that is pathogenic, meaning they could be just as deleterious in terms of causing cancer. Mm-hmm. And in those patients that are considered extremely high risk, the option to do bilateral mastectomies is definitely there as an option. That does not mean, that doesn't mean that they need to have mastectomies. We watch people very, very closely with breast MRI now. So the recommendation from a conservative standpoint is to do a mammogram, 6 months later, a breast MRI, 6 months later, a mammogram. So they're alternating every 6 months doing imaging, but we're using a different modality to screen them. So if you're on top of it and you're screening that patient twice a year using other modalities like breast MRI, you're going to detect something at an early stage. You're not going to miss that. You're going to detect it very early.
So when did MRI come into vogue for breast cancer screening and evaluation?
Breast MRI came into play about 10 years ago, where it came down from the American Cancer Society that people that are considered high risk for breast cancer, and what I mean by high risk is they've got a greater than 20% lifetime risk, of developing breast cancer, then those are patients that qualify to do a breast MRI annually. But now that does require an insurance approval, so insurance has to approve that. But those, according to the American Cancer Society, that's the recommendation.
Okay. Hey Lance, is there anything coming in on there, or are we totally flat?
Oh, you're perfectly fine.
Okay. Any questions coming in? Because sometimes people can write in questions. See, no questions. We got to grow this thing, April. You got to put this. Yeah. You got to put this on your website. You got to get Prim to share it with the world.
There's Carrie Ford and Katie Spear watching.
Okay, super.
And then Carrie Ford said, "I had invasive
lobular breast cancer." Mm-hmm.
What does that mean, April?
So lobular breast cancers, they account for about 20% of breast cancers. And lobular carcinomas are just a type. Lobulars can be a little tricky, though. They are the ones that a lot of people will say, my mammogram did not detect this.
She says she has an MRI.
Perfect. The MRI is the best in terms of detecting lobular carcinomas, actually. And so oftentimes patients actually feel their lump when it comes to lobulars, because lobulars oftentimes get missed with mammography. Now, I do think that the 3D mammography that we do now, that is beginning to become the norm out there, replacing the 2D mammography, 3D mammography does do a better job of detecting some of the lobulars than the 2D did. But even then, sometimes it'll miss it, and so ultrasound is good. If you feel a lump, ultrasound it. Or people that are even concerned or fall into that high risk need a breast MRI.
Okay.
And so, an MRI is actually good for her because it's going to look at both breast, and lobular carcinomas, they can affect both breasts.
So I want to touch on two things. I want to touch on screening and treatment. Okay. Mm-hmm. Screening. Where are we with breast self-exam, mammography versus MRI? Just sort of take us through the recommendations, or what your recommendations are as far as just general screening from beginning to end.
Right. So we still nationally, the recommendation is that mammography starts at the age of 40 annually. So at the age of 40 annually, mammogram screenings start. Okay, and they go every year. And some people say, well, how long do you get them? Do I go at 80? And I say, yes, if you're able to get up and drive or get up and walk around, then you're able to go get your mammogram, then yes, you get it at 80. Mm-hmm. Because some people live to 100. So I think that depends on quality of life, right? Like if you're up and running and doing, go get your mammogram. In terms of a baseline mammogram, what we like to say is start your baseline at 35. Get one at 35 so that they have something to compare to when they start at the age of 40. We still recommend that people do monthly self-breast exams. Even if you're very cystic and you know you're cystic and you have lots of little lumps or bumps, I still tell my patients, always check yourself. You're going to check yourself in the shower anyway. You're soaping it up and lathering up, right? Mm-hmm. But you should check yourself because you will be the first person to detect something that is not right. You will be the person to go, you know what? That wasn't like that before.
Update from Carrie Ford. She says, I had an MRI yearly and I found my lump. Never seen on us or Mammo. And Jamie Stalling says, she is the best. Did my surgery in May.
So don't use any last names, but that's fine.
That's so sweet. So yes.
I get that a lot, by the way, April. I had somebody tell me that they had a lump, and that she was actually fine with it.
Yeah.
But you weren't able to sleep at night until you got it taken care of.
Right. No, I mean, sometimes that's the way it is. Sometimes I just feel something on patients and I just kind of say, my ultrasound's not showing anything, but, I just don't like the way it feels. And, I kind of say, you know what, I want it out. Let's take it out, because if it's still there, I'm going to be the one not sleeping well. I'm going to be thinking, God, did I miss something? Did I miss something on somebody? And I can't sleep, so she might be sleeping fine. But if I can't sleep, we're going to do something.
That's right.
And even if it's an MRI, I'm going to be like, no, she's getting an MRI because I really want to make sure there's nothing going on. So
treatment. I want to get to treatment a little bit. So I want to talk a little bit about medications. It seems like that has come a long way. And of course, I want to talk about surgery because that's what you do. So jump in wherever you want.
Well, I think that the mainstay of breast cancer in terms of surgery is still lumpectomy with radiation as the conservative approach, and we have a lot of patients that do that, and they do really well. And one of the reasons that these patients do really well with lumpectomy and radiation is because we catch things early. So when we diagnose things at a stage 1 or even stage 2 or stage 0, we're diagnosing early, we're nipping it in the bud. And so those patients are going to do great, and they don't have to have some big surgery. There are other patients that a bigger surgery like mastectomy or even like double mastectomy with reconstruction is still the better option. And it may be because the size of the tumor, it may be the distribution of the tumor, and that is if they kind of have a multicentric type of finding in more than one place, then you're not going to...
So this becomes an aesthetic issue, a
yes.
cosmetologic issue. This is
right.
where I wish you could show me pictures.
Before
and after. No, seriously.
Didn't bring any pictures.
But next time.
Next time I will.
But again, I'm in my brain, and I think in the brains of people that are watching this, they're like, oh, that just, I don't know.
Yeah.
Tell us how that turns out aesthetically.
So aesthetically, one of the reasons why a lot of the double mastectomy numbers have increased in this country has because of the plastic surgery. And that is the reconstruction options are excellent now. The implants are better. They are silicone, but they're still a better implants than before.
Why are they better?
It is the texture that they use with these implants. It's also the shape of the implant. You've got different shapes, like a low profile one. You've got the round. You've got different ones. I'm not the plastic surgeon putting those in, but we help in kind of each other on all of this in terms of, hey, this patient said they would like this type of shape, or this patient said she wanted to be smaller. So there's a lot of plastics that comes into reconstruction, and the results are really excellent now. And even with tissue flaps, we still do a large number of tissue flaps and take them from other areas of the body, especially like latissimus flaps and tram abdominal flaps. There's still a fair number of that going on, and they get excellent results, and the patients are happy.
Are there any questions on that, Lance? If there are, just because this is sort of so far away from my expertise, right. I'm not even sure what to ask you about it. And
then the other thing is even with breast conservation, which is the lumpectomies, we do a lot of oncoplastics now. That is a combination of oncology, but with a plastic approach. And that is, we can take a 3-centimeter tumor out and give the nipple areolar complex a little lift and help shape the breast. We also have devices now that are almost like an implant, but it's really a marker for radiation. It's called a biosorb, and we use these implantable devices that actually dissolve over time. They're like a vicryl suture, and they dissolve over time, but they actually have a little spiral shape to them, and they kind of fill the void where you do the lumpectomy, and then you can kind of shape the tissue over that, and then that helps from an oculoplastic standpoint to kind of reshape kind of the breast to give a natural
Truly,
look.
I need images, honestly,
yeah,
to really understand what you're saying. I really do need images. But How about medications? Where are we with that?
Right, and now with so much research now, breast cancer is being treated a whole lot differently than even 10 years ago. So, we have different regimens now in how we treat breast cancer based off of the type of cancer that it is. And so if you have something called triple negative breast cancer, that's a fairly aggressive breast cancer. It is associated with genetic mutations like BRCA genes, so all those patients get genetic testing. But all of those patients get chemotherapy also because of the aggressiveness of those. But those patients overall do very well. There's also new things on the horizons that we're doing a lot with immunotherapy. Immunotherapy is being done in the triple negatives. And then also a subgroup of breast cancers that are called HER2 or HER2 positive breast cancers. They all get chemotherapy, but the agents that are being used like Herceptin and Perjeta that we give a lot of times before surgery, we try to do that before surgery and shrink it down because we really want to see what the response is to the chemotherapy. We don't really want to guess at what we're doing. We want to give it, know that it worked, and if it works, then the survival curve is so much better. We know those patients are going to do great. If we give them the chemotherapy on the front end and it shrinks that tumor down, hopefully that it shrinks and you can't even find it when you go to operate, then their survival curve is excellent.
How do people find you, April? Is there a website? Is there an office number? Is there an
There's an office number.
Give all that.
Yeah, so my website is breastcarecenterofbirmingham.com. And then my office number is 205-877-2987.
Perfect.
Yeah.
Anything else you want to say to our 3 viewers?
I just wanted to say I hope everybody went out to run the Susan G. Komen run today, this morning down at Regensfield.
Perfect timing, actually.
Yeah.
Lance, thank you for helping out today.
Oh, you're welcome.
Okay. I guess you can stop
Thanks,
it.
Brad.
Thanks.